what is your, you don't do unrestricted KA? Or do you do a restricted kinematic alignment?
So, Dr. Maria, most of the times I found that you don't need to go beyond 5 degrees of varus.
No, you don't need to go is different.
Yeah.
What is your limit? Are you present to?
I have gone up to 6 degrees of varus, but my limit would be 5 degrees of varus on the tibia and 3 to 5 degrees valgus on the femur in varus phenotypes.
All right, so this is the most strongest proponent of the kinematic alignment, and he has boundaries. I think that is the message to take. Thank you very much. Great presentation. So, we start, Sanjeev.
Okay. My question is to, sorry.
Rajesh.
Okay, go on.
Can I talk?
Yeah.
Yeah, just 2-3 observations and this thing. We have done 8,000 robotic knees now. And my feeling is it has liberated us from being slaves to mechanical alignment. And inadvertently, we are putting non-mechanical alignment all these days. We have got a paper following the Mayo Clinic Berry's paper. 700 knees of our own 15-year follow-up, 45% are non-mechanical. Though we thought I put mechanical.
These are with the robotics.
Robotic. No. The ones we have put before. Okay. So what I mean to say is all of us, what we thought we put in mechanical or not mechanical, they are adjusted mechanical or like that. So what I'm trying to tell is 3 degrees varus or 5 degrees varus, even without robotics, if we do it now, heavens are not going to fall. Right. As Amar said, it is end of the day balancing and putting the knee stable is correct. But I beg to differ on 2 points. Last one with Amar and Ashok, all soft tissue release is not the same. It is a soft tissue envelope which we forgot to respect so far. Probably robotics has told us to respect the soft tissue.
All right, your point taken. I think that you aim 0, but you may not reach 0.
Absolutely.
It doesn't matter as long as you balance.
Exactly. And the less soft tissue release, the better it is. There is no doubt about it.
The panel will agree to that. We have a lot of questions, and I would request that everybody short questions, and there will be a short answer.
So is that case can be done in each and every cases, and I think it's known that the soft tissue stability is the main, and that's what the alignment philosophy taught us.
We'll ask only Anup. Anup, KA can be done in all the 100% of the patients?
No, it's 75% cases. So the cases, severe deformities and uni, so 75-80% cases gives us that great window of opportunity to explore KA rather than doing MA in all cases.
But
Rajiv, next question. You can ask him later.
In the quest of least ligament release and adjusting it with the bony cuts, sometimes we are having recently I have operated a few revisions where the femoral component was in excessive internal rotation. So the panel's opinion about it that in the quest for minimum ligament release and adjusting it with the bony cuts, are we probably committing a lot of mistakes of femoral internal rotation and not giving so much of attention to the patellofemoral joint?
So let us ask Vaibhav. Vaibhav, can you answer that?
No, I think you should be well versed with the technology that you are using. Mistakes can happen with anything, but if you do it, if your boundaries are there and you respect it and you execute it well, it won't happen. So learn the technology. I mean, technology is there, but if you use it, it will execute it to the precision. And sub-millimeter, sub-valgus, sub-degree.
And a degree of rotation, but if your tracking is correct on the, shouldn't matter.
Right.
Dr. Sanghvi?
Question to Dr. Manyar and Dr. Rajgopal regarding the soft tissue releases. Rajgopal, sir, you said almost 0% for superficial MCL release, whereas sir, you said almost 30%.
No.
So can you?
So when I was doing pure mechanical axis alignment, my soft tissue releases because we deal with severe patients, and I would not want to leave behind any patient imbalanced on the table. So I would had to touch the medial collateral ligament in about 30% of the patient. Pure mechanical axis alignment I'm talking about. And it's not a full release of MCL, superficial MCL. I used to titrate it because navigation. So just a little bit, just a posterior corner like what Whiteside has described. But yes, ever since I have been using the functional alignment, my release rate has gone down and at least by 50%.
Yes. Dr. Rajesh? Dr. Rajesh Manya? This functional alignment, it's not in the true sense, it's not an alignment strategy. It's more of a philosophy. Both your restricted kinematic and restricted mechanical alignment, this comes in the functional alignment category. So it's more like a philosophy.
Okay. Yes. So
maybe I'll just add to that, because I listened to 7 people up here try to argue with each other, but really all say the same thing. So the mechanical axis guys don't do mechanical axis. They say, well, it's kind of mechanical axis, and then I cut a little bit more this way, or I cut a little bit more that way, closer to the patient's native anatomy. Then I listen to the kinematic alignment guys say, well, I'm not unrestricted. I have some restrictions, so I'm closer to the patient's normal anatomy. So I think what everybody is saying is that we're not strict mechanical axis. We're probably not strict kinematic. We're closer to the patient's native anatomy, whichever direction you come from, and we probably need to spend more time looking at rotational alignment, which we've totally ignored with things like CPAC classification. Would you guys agree with that?
Well summed up, but the only difference here is that when you are trying to do a little bit of adjustment here and there, it's a tough thing to do if you don't have a technology guidance.
Yeah, so
therefore, I think for the mass, if they are going to do it with manual, better aim 0 so that you go a little bit here and there, it doesn't matter.
I think that's a good point.
So, David, what you described in other words is something nearer to a functional alignment.
Yeah.
So that's what we are aiming for.
And that's what everybody's kind of getting closer to, it sounds like.
I think everybody has recognized that less soft tissue release is going to benefit somewhere.
The bigger question
Dr. Maniar, I think we keep saying soft tissue release. It's minimum ligament release. Soft tissues, posterior capsule, you will still do in a fit So I think we should really say ligament release.
Yes, ligament release.
And the bigger question in my mind, David, is whether you need technology to get that functional alignment. I think that's a debate. That's just a very philosophical statement.
Rajesh, just another point. Right through this panel discussion, we've been talking only about coronal. I think the critical issue with stability in the knee is sagittal plane.
Correct.
Restoration of the...
Let us first understand the coronal, then we're coming to that next time. So, Asit.
Yeah, so my question was exactly the same, what Dr. Rajgopal said, that we all have been concentrating only on the coronal plane and not on sagittal plane. So, Anup, on this kinematic, philosophy, what happens with the posterior slope? Because Stephen Howell's paper says that the worst combination is the varus and the posterior slope where you have erred. So, what are your limitations of sagittal?
So, flexion of the femoral component is as important as the tibial slope. Those two things are very important. And the flexion of the femoral component should not be more than 3 and 5 degrees because that will affect the patellar tracking. That's one. The slope should not be more than the original slope. That's usually 5 to 7 degrees. So you got to replicate that. And in sagittal plane is where technology is of real help.
Right. So you keep that posterior slope how much in that your kinematic alignment?
Not more than 8 degrees, usually between 5 to 8 degrees, wherever the balance comes.
And yes, so our patients osteoporosis in our patients, does that change your way you put your slope or the varus alignment? Because that is important as compared to the Caucasian population.
No.
Okay, so microphone 2.
For Dr. Anup. So the first thing, the kinematic instrument that you showed does not have a rod, is not right, they have a rod. It's just they have an oblique slot that it does not correct the valgus varus, it corrects the flexion and extension.
No, it doesn't have a rod.
Because
I'll forward you that paper, that they don't have a rod. Basically, they have shims and posterior condylar, so you basically cut equal at the right flexion plane.
The kit that is available in market by Howell right now, it is a 10 centimeter rod. It is just for the flexion and extension.
No,
the
instruments have a rod.
You can discuss that.
Yeah.
And we'll ask Marothi.
Yeah, my question to Dr. Jurani, excellent presentation. In your KA group, are you restricted with any implant type? Like you are telling that no ligament release. So you are restricted to CR only or you using PS as well?
So CR, but the main issue in valgus knees is that they tend to have more patellar issues. So you need to use broader implants, not narrow implants, especially when you are handling valgus knees.
Okay.
So we have only 1 more minute. I think we'll take this many questions.
So the last basic question. In a severe varus fixed deformity where you cannot correct it and there is a bone loss, the tissues are contracted, is the MCL contracted or is it not? Because I read in some of the articles, it is not supposed to be contracted. And if it is not, then what are we releasing?
Sorry, can you say that again?
In a severe fixed varus deformity, when there is a medial contraction is not correctable by valgus, is the MCL contracted?
So I think most of the time it is tented over the osteophytes or the deformity, like what Vaibhav said initially. Has the varus caused the arthritis or the arthritis has caused? I think it is a perpetual thing. One increases the other. Actual contraction of the medial collateral may not have occurred, But what does happen is that the lateral collateral may have stretched, and therefore you need to balance.
So there are studies which have studied in great depth what happens to ACL and SMCL. So ACL, the collagen morphotype is much different than SMCL. So the degree of contraction is much less than compared to the ACL and the other ACL and PCL. So ACL and PCL have shown to be definitely contracted or shrunk, whereas SMCL does that, but to a very smaller degree.
It does contract to some extent.
So I think the last two questions, and then we. Is that okay, Parag? Can we go on?
Sorry, I just want to make a quick comment. I've been taught by Dr. Steve Howell and done almost 350 unrestricted KA knees for the last 1 year, and I don't go with any x-rays inside the OR as well, because everything, all the measurements happen intraoperatively right in front of your eyes. So we were having a discussion about how we assess the bony defect, and we don't assess the bony defect here. We see the threshold, the tide mark of the cartilage, and that's how we assess. And somewhere, obviously, always you will, anytime you see, there will be some amount of cartilage preserved. From there onwards, you can start building it up.
I think
so that's
excellent.
How I do
so
it.
we will look forward to your results and your paper on this, because Howell does not have such severe deformity that probably you're dealing with. Very good. Thank
So you said that you don't go in the OR without X-rays?
I don't even see X-rays.
So if you have a stress fracture or extra-articular
like pre-operatively, yes, of course we will take the X-ray, but I don't have the X-ray for my reference. How much slope should I keep? I just go with the natural slope. Yeah, so, all right.
Yes. So what percentage of patients where you are using the technology to achieve a functional alignment, once the cuts are done, what percentage of patients in your practice you need to tweak either a little bit manually as well at the end of that alignment to achieve what you are desired result in that patient?
No, I'm not sure I understand. Does anyone, what is the question? Can you?
The question is, sir, using the technology, once with the cuts are done, what percentage of the patients you need to do manual changes into that to get a satisfactory result? So though on the screen the result is perfect, but when you are looking at the joint, you need to tether it a little bit.
Technology.
Yes, I'll answer that. It's a very pertinent question.
What percentage of patients do they
For 1
need?
year, between 2009 and 10, we did all the knees using OrthoPilot with gap balancing. And we found exactly the problem that you are alluding to. The reason is that you can never know the amount of gaps until you have actually released the posterior osteoids, taken them out. So till you have done your femur cuts, you can't actually know what is the soft tissue laxity. So the answer we found was that we do a modified measured dissection technique. We don't rely on gap balancing now.
Okay. So, sir, one more question, sir, please.
All right. So, since Dr. Anup is new in the panel, I am just asking him, do you do true kinematic or you do restricted kinematic?
So, true kinematic, absolutely, but there is, after 5 or 6 degrees virus on the tibia, that's my boundary.
So there is a restriction.
That is a restriction.
Okay.
So last one.
I think Dr. Mukhi, really the last question, because I think we are really running out.
Does the ligament have elastic tissue to contract?
That's what Vaibhav answered.
So I'll answer you in great detail that we can have it. So I'll tell you.
Don't release the ligament unnecessarily.
Okay.
Cut less.
All right.
And release less.
Taken your point. Thank you very much. And all of you, please go away with that idea that think about less and less ligament release, but leave your knees balanced.